Okay, so this is my ID. Okay, and today I'm going to be discussing about my question. So my question that I've chosen is, what is best practice strategies used by nurses to de-escalate aggression behavior in mental health and emergency department settings according to qualitative research? I chose emergency departments, so get straight into it. So I'm going to share my screen. Okay, so this is going to be first, I use Cina, and then we're going to get into the database. And then I also used Medline. Um, so now, and then we'll go back and we'll open Medline too. For my advanced search, I did qualitative. Okay. And we're going to do the same thing here too. I think it's doing it for me. So yeah, you can see the proof of evidence there. And yes, this is exactly what I had before. Okay, so the reason to why I changed the wording was because I used truncation because I almost got close to no results within my search. So to help widen my search and to get the answers to my question, I had to truncate most of my um, words. So my word vocabulary would be broader. Now for these specific, um, so we're gonna go through one by one. And first of all, we're gonna start with David. Now, so if we go straight into it, we'll probably start here. Okay. So David's main point was that in in emergency departments, they redesigned their response to aggressive patients called Code Black and using a structured chart with warning signs to help and a clear step-by-step plan to help talk to the patient first, medicate, and if necessary, then only restrain. Now, the evaluation of this was strong evidence that was real and measurable and improved, but not only with staff opinions. Now, it also matches the recommendation of best practice of talk, medicate, and then restrain if necessary. Now, the main weakness is that there was staff shortages and it still got in the way. So not only the tool alone could compete to fix it. Overall, it helped with nurses to help share a plan, make everything clear, communicate safely and professionally within a correct practice. Now, next up is Martin. So if we go down to here, Martin is his main point was that the study asked New Zealand ED nurses what helps them cope with violence and aggressive patients before, during, and after an incident. Now, the only support given in this was huddles. Flagging risky patients early would be helpful. And this would help in experiencing the nurses in each shift to show calm behavior and be that role model, and to apply that toughen up culture to help stop people from asking for it rather than helping them out. So the evaluation of this was completely valuable as nurses' lived experience, which added real-world credibility. However, they only used 6 interviews from one hospital, so the findings cannot be assumed to apply to everyone and everywhere, but it's a starting point, but not a definite answer. Next one is Raisman. Raisman also, if we look here, if we search, if I press search, then of course I'm going to get it. So Risman is For him, it's more that he created 27 doctors and nurses across 19 German EDs and asked them about what violence prevention measures they know and whether if they actually worked. Now, the support was verbal de-escalation by staying calm, listening, explaining the waiting times, and also to recognize warning signs such as pacing, clenching of fists, sweating, and also creating, even though there's no formal guideline and no tools to help predict, um, the warning signs is what help them evaluate. Now, for the evaluation, for further evaluation, it's a well-designed qualitative study because it follows the proper qualitative report standard according to Germany. Now, the only and which this applies credibility in Germany. However, because we're in Australia, it doesn't correlate with healthcare systems as they differ. That's the only issue with this, because otherwise all everything would be better. Now, the second last one is Wong. For Wong, his main study point was that he had asked patients, as he didn't ask nurses or doctors, he asked patients whether if they have been physically restrained in the ED and their experience. And these were over 95 real agitation events. So he asked the patients to see whether if their idea was different to the nurses and doctors. And so this the support given to this is that staff explained much better things calmly with decisions, and reinforcing rules to people who needed them and required them, and also de-escalation worked best with staff working in teams rather than on their own. And they linked the aggression of patients with past trauma, homelessness, or feeling ashamed or unheard. Now, this is very valuable resource because yet again, it includes the patient's voice and rights as a human, and it's very holistic. However, the US healthcare system, that's the only limitation, is that the US healthcare legal system is very different to the one in Australia. So, and it doesn't connect directly. And the final one that I do want to talk about, so yet again, we got Sutherland, who his doesn't really answer much. Um, David's and Benning. Benning is also a common one, but I didn't really like Benning's. I feel like there's another one that's a bit more better. Now, this has been saved in my recent search, but when I was doing my first search, it wasn't there. So it wasn't in my recent search. So if we go back, recent activity, and if I go press on this and get rid of the 5 years, you will find it. I don't know why it works like this, but it works best like this. And he will be the first one to pop up. Yes, so Ouyang, the reason why Ouyang is probably the best one is because it commons the common problem. So the main idea was the common problem among EDs is that the violence risk once at triage, the nurses let a pathway keeps checking risks throughout patient's visit and to check whether if there are any triggers and whether if nurses notice any behavior and not waiting for a single dramatic moment. So the idea of looking out for certain warning signs and high risks and for like moderate risks and looking for calm communication, keeping it low risk, but also um, and keeping in focus groups, so having groups where nurses would be with more experienced nurses, and then they would watch the more experienced nurses see how they read the room to, before anything escalates. Now, the only good thing with this is that it is very recent, explicit, as nurses led combines real numbers, nursing own words, giving a clear, usable model. So, like low, moderate, and high risk. The only weakness is that this is only tested in one hospital in 1 month, and it hasn't been proven to reduce violence, but in long term, but this requires more research. However, this so-called gut feeling, I feel like helps with nurses practically, but also helps them be more responsible in professional nursing practice and supporting patient safety as well as professional accountability. And that's all. Yeah, and that is it. Thank you for listening.